Great. Okay. Welcome everyone to the September Family and Patient Research Q&A. We're so delighted you are here. As ever, we pick a topic and a theme each month, and we're here for you. Please ask questions, please interrupt, and I will now hand over to our Mel, who's going to take us through some of the process when it comes to stenosis and fibrosis.
Thank you, Kate. So first, before going to stenosis and fibrosis and whatever, I just want to remind you that what's Myhre, what's the issue with Myhre, is that you have a mutation in SMAD4. Very specific mutation, as I explained last time. You can have a mutation on the amino acid 496 or 500. So you have what we call the SMAD4 protein that doesn't work properly. It works in a pathological way. And so what does it do, the SMAD4 in your body? So in the cell, the SMAD4 is going to be involved in the nerve axonal regeneration, in immune response, in structuring connective tissue. So that's also why we say that Myhre is partially a connective tissue disorder. So it means that the connective tissue are very specific tissues, and it produces the blob that you have in between cells. SMAD4 is also involved in regulating cancer, and it's involved in bones disease. So just to make you understand that because you have a SMAD4 that is not working properly, you are going to have some very specific organs that are not going to work properly. So why can't I go to the next one? Okay. So today I would like to talk more about something that concerns, I think, every one of you, is the stenosis. That's a risk. It doesn't mean that all Myhre patients are going to go through stenosis, but it's really really a worry for most of you. So what's stenosis? It's the result of an overzealous wound healing mechanism. So everybody is able to have healing of any wound. So that can be when you smoke, it can be when you cut yourself, it can be when you have when you eat too much spicy food. It creates a stress on the cells and it can create a wound. And then you have a mechanism, natural mechanism in your body that starts and stops. The issue with fibrosis is that this wound healing mechanism starts but overdue and sometimes does not stop. So that will give rise to hypertrophic or thick scar formation on the skin or anywhere where you have a wound. So to do it in the other way. So first, I would like to explain what's the wound healing process, the normal one, not the one with Myhre patient, but the normal one. The first part of the process is inflammation, where you are going to remove all the pathogens, which means the bacteria, the virus, if you have something like a piece of metal, your body is going to react, your immune system is going to react and try to remove this foreign object. Then you have the proliferation, the extracellular matrix deposition. So it's a kind of glue that is going to be produced and that will stick at on the wound place. It's usually made of collagen. So I'm sure you have heard about collagen even for skin products or these kind of things. So it's collagen. There's a lot of different proteins, but collagen and fibrin are one of those. So you have a deposition of this kind of glue, and you have what we call epithelization. So when you have an epithelium, which is some cells that are on your just in, it's the barrier on your skin, on different organs. It's a kind of barrier, if you want to say it in a simple way. So you have the proliferation of the cells, the production of the glue, and the barrier that is put back. So you, in fact, establish a temporary scaffold for the tissue to regrow. Because when you have a wound, usually you have a hole, you have a break. And then you have the maturation, where you are going to create the fibrous scar. So everybody has seen a scar. And you are going to remodel, in fact, the tissue that was damaged during the wound. So just to give you a visual support. So you have the wound, you have the bleeding. That brings all the immune cells that are going to be part of the inflammation. Then you have a proliferation of the cells that are under it. Where there was a hole here, you see that the cells start to proliferate. You have the proliferation of the cells under it, production of this kind of glue that I was saying, which is the extracellular matrix. And then you have the regrowth of the epithelial cells that are going to be part of the barrier. And you have what we call the maturation. So the maturation is going to be the end of this process, because you cannot go on and on and on. But you have the end of the process when you have a normal wound healing. In case of abnormal wound healing, the end of the process is not achieved properly. So you have, that's just an example for the skin. So first you have rupture, you have the blood comes, there is coagulation of the blood, you have all the inflammation, the different cells coming from the immune system. Then you have a proliferation of the cells. So epithelialization, so that's the barrier of an organ, of the skin, for example, here. And you have what we call endothelial cells that are going to recreate vessels for your blood to come in again. And you have some cells that are fundamental, and I'm going to talk about that a lot today, that are called myofibroblasts. So the myo is very important. And those myofibroblasts are the ones that are going to produce this glue. And then they are supposed to die and end. So we call them myo. If you take the origin of the word, myo is associated with muscle, because those cells, strangely enough, from a normal cell that will create and produce this glue, the extracellular matrix, is going to acquire the capacity of contracting like a muscle. So we don't call them fibroblasts, we call them myofibroblasts, because they have the ability to contract, sorry. So when you have a normal wound healing process, you will have the remodeling, where at the end, where at the end, everything stops and those cells die. They are going to first to contract, to really gather everything and localize and minimize the size of the proliferation, because then if you have this production of the glue, you cannot leave the glue go everywhere, and you cannot let all the cells proliferate and go over and over. You need to contain them, and then they need to die, because otherwise they would go on. So the problem with hypertrophic scars is that this end of the process doesn't occur properly. So the difference between wound healing, which is scarring process, the difference between that and fibrosis is that the wound healing is a normal process to restore the structure and the function, but the fibrosis, it's when this process becomes pathological and when injury does not heal properly. So basically what we think now, but that can change, science, knowledge in science can change all the time, is that the main issue is the ending of scarring. So it's the myofibroblast that should contract and contain the scar that stay too long, and the myofibroblast that should die, what we call apoptosis, are not dying, are staying there. So that's the hypothesis for Myhre syndrome, is that we have those myofibroblasts that stay there. The fate of myofibroblasts during the remodeling really determines whether the wound closes or continues to develop in hypertrophic scar. That's known for sure. We have never looked properly in Myhre syndrome patients and analyze really properly what's the proportion of myofibroblast in the scarring. So we don't really know exactly, but we know that usually when you have fibrosis and hypertrophic scars, it's because of the myofibroblast. And really the myofibroblast, I want you to understand that they are the cells responsible for the progression of the fibrotic process. So I'm going to stop there and just ask you if you have any questions. Do you understand the process? So maybe I can go one more.
Can I ask a quick question?
Yeah, sure.
Is it possible to test the severity of the fibrosis? Does that make sense? Like if Katie cuts herself, is there a way to test if ever she did have an injury or needed surgery, how extensive her fibrosis would be?
No, I don't think so. You cannot test in advance how she's going to react. So the thing we start working now in the organization is to work on those myofibroblasts, and I'm going to explain what we are going to do. But you cannot say in advance that your fibrosis is going to be extreme or not extreme. So that's unfortunately no. There are no tests for that.
Okay, thank you. Because if Katie's gonna have surgery, I would have liked to have known if there was a way to test how quickly the fibrosis would grow. And is it possible to get stenosis without without being wounded or the skin being damaged?
Well, you can have chemical
Okay.
damage. In fact, you never know what kind of aggression or stress on your cells. But if you have the beginning of an inflammation reaction, then that can trigger all the fibrosis that will trigger the stenosis. So even bacterial infection, smoke, so many stress for the body and for your cells can trigger inflammation. There's a lot of diseases that have fibrosis that are just that are autoimmune diseases. So it's even your own body that starts the inflammation and start to attack your and trigger the wound healing process that becomes fibrosis. So there are so many different factors that can trigger the beginning of a wound healing process, that you cannot predict that. You can be attentive, and if you go to the ER or if you go to for surgery, definitely the clinicians need to know about your disease and the risk of hypertrophic scarring and fibrosis. That's something that is extremely important for the Myhre patient. So so really that's to summarize that the wound healing has three phases. The first one is inflammation. The second one is, so you have a cut, then you have the blood arriving, or all the immune system is coming, even if you don't have a cut. When the immune system is triggered and you have inflammation, then you will have, the next step is going to be a proliferation and a transformation of some cells into myofibroblasts. And then you will have the remodeling, where the cells are going to be contained. The glue, the extracellular matrix, is going to decrease a little bit. And finally, all those soldiers that were there and all those cells that were there to reconstruct are going to die. And that's the end. The issue is that if you have a disease, so you have a lot of molecules that triggers the phase, and you have other molecules that are going to allow the ending of the phase. So if you have any issue with those molecules, then you can be stuck in one of the phases, or you can have phases that are not triggered. So the whole balance between the beginning of the process and the end of the process, or trigger the process and not trigger the process. So that's this balance that is important. And in Myhre patients, in some tissue, you don't have this balance. You don't have fibrosis everywhere in your body. But in some tissue, you have a problem with this balance. You have a problem with the end of the wound healing. So what's interesting is to understand where those myofibroblasts come from. So for Myhre, we know that you are not going to have fibrosis in your fat tissue, for example. But you will have fibrosis in aorta. You will have fibrosis in the LT, so trachea and some very particular part of your body is going to have fibrosis, but not everywhere. So we need to know what kind of myofibroblast we have in Myhre. So the myofibroblast can come from either the fibroblast, as there is this name. It can come from what we call endothelial cells that are usually in the, you can find them in vessels. They can come from epithelial cells, like in the skin, for example, or they can come from, in fact, the immune system through the monocyte and fibrocyst, and then become myofibroblast. So we cannot investigate all of them. We cannot take tissue from every part of Myhre patients when they have fibrosis and try to understand where they come from. But what we can do, oops, again, not the right button. What we can do is investigate really and answer some very precise questions. So the first question is there a prominent origin of the myofibroblast in Myhre patients? The next question is, does the Myhre syndrome pathological protein SMAD4, as I explained you, that's the issue is that you don't have the right SMAD4. The shape of the SMAD4 is slightly different. So is it going to activate other components, what we call pathways, that are involved in myofibroblast? So I'm going to explain better. So you have the SMAD4, normal SMAD4, that comes binds to another protein and trigger the formation of the formations of new proteins through their genes. The issue with the SMAD4, if it's pathological, if it's a little bit with a different shape, it might stick and form a complex with another type of protein, and that will trigger other proteins and other genes that might be involved in the formation of myofibroblasts where they shouldn't be involved with a normal SMAD4. Am I clear, or you don't follow me at all? Ooh, I killed you. Okay. Okay, so that's another question. So where does the myofibroblast come from in the fibrosis for Myhre syndrome? Are we still exactly with the TGF-beta pathway, or do we have another one coming that can trigger this new myofibroblast that shouldn't be there? And the next question is, how can we regulate the myofibroblast fate in Myhre syndromes? That's the most important one, in fact. How can we prevent those myofibroblasts to produce again this glue without stopping, and they don't die, they stay there. So how can we act on that? So we have some projects. One of them is the what we call the preclinical fibrosis platform, where we are going to observe the formation of myofibroblasts from patients compared to siblings. To answer the next question, which was, do we have these myofibroblasts because we have now a SMAD4 that can trigger and interact with other protein where it shouldn't trigger and interact with? So that's a project that is called NeoPPI. So that's very fancy, but it means protein-protein interaction. And we want to identify new or abnormal protein interaction between the SMAD4 from Myhre patients and other pathways. And the last one, how can we regulate the myofibroblast fate in Myhre syndrome? Still in the preclinical fibrosis platform that we are developing, we will have assays that really test treatments on those myofibroblast formation and regulation and see if we can modify that. So we cannot, you saw how many possibilities there are from a myofibroblast to be created. But we cannot explore all of them. That would take a lot of time and a lot of money. So we focused on three different ones. The epithelial, so that can be transformed. So you have the epithelial cells, you remember, that was broken, and then you have the proliferation. The issue is that you have also those epithelial cells that can be transformed into myofibroblasts. So that's what we call the EMT. So from epithelial cells, they are going to become these myofibroblasts. So those muscles that can contract and that produce the glue. So if we can regulate that and have less of them, maybe that would be an answer. The other origin we chose to study is the fibroblast itself. And the last one is the endothelial cells that can also become myofibroblasts. So every time, if you look, I don't know if I can go back here. In fact, I want you to pay attention to what's written here. TGF-beta, 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 TGF-beta. Did you follow what's the TGF-beta link with SMAD4? So I'm going to go back.
Quite remind everyone how that interacts. Yeah.
You see that SMAD4 is here. So that's a cell, sorry. So that's the representation of a cell. And on a cell, you have it's a kind of balloon cell. And on the membrane of the balloon, you have receptors that go through the membrane and that are going to receive some signal and then tell inside the cell to produce new protein, for example. So you have one of those receptors at the membrane of the cell, this big balloon, you have some kind of antenna that goes out, and that's here. So that's represented here. And you have one molecule that is called TGF-beta or BMP, which is a different type of, it's in the same family. So this TGF-beta is going to bind to this antenna, to the receptor, and then it's going to tell SMAD4, go on the gene and produce new proteins. So if you have TGF-beta coming on your cell, binding to the antenna, it's going to tell the SMAD4 to do something. And you have this issue that SMAD4 is not doing what you want them to do in Myhre syndrome.
And Armelle, this is back to our factory manager. So it's receiving a cell it's receiving a message to produce, we want to produce 200 cars. The message it's received is, I've got an order for 1,000. Like, it's getting the wrong message. And that is then disrupting the process in our factory for what we should be doing. So is that right?
Yes, exactly. So you have, for example, the myofibroblasts, they have those, and whoops, what's happening? They have those antenna here. You have the myofibroblast, which is a kind of balloon with arms around. And you have those antenna, and they receive the message from TGF-beta, but then they are going to go, the message is going to go through the cells and talking to SMAD4. You have to do that. And then SMAD4 starts to do it, but do it over and over and over and over and never stops. Yeah. Works too much. And what I suspect is that it tells, okay, I'm going to do that, and starts working, and it's going to talk to the neighbor where it shouldn't be talking to the neighbor.
Yeah.
And he's going to say to the neighbor, oh, but you should work also on those different ones. So that's the issue.
Yeah.
So if you see that you have a process in the body where TGF-beta is involved, it means that it's going to give this signal on those antenna in the cell, and the signal is going to go to SMAD4, and SMAD4 is going to do mistakes. It's going to not work properly. So when I should escape and go directly. So when you see that you have here this process that involves TGF-beta, you know that this process is involving SMAD4 at one point. So of course, this is going to give the wrong signal or too much of the signal. And on the myofibroblast, you also have those antenna. And it tells the TGF-beta to the myofibroblast, tells produce the glue, produce the extracellular matrix. And the SMAD4 goes there and said, produce the glue. But the Myhre SMAD4 said, produce the glue, produce the glue, produce the glue, produce the glue. So you have a lot of extracellular matrix, and you have the scarring that becomes really huge, and you have fibrosis. So the fact that we have TGF-beta in all the different type of, all the different ways to produce myofibroblast, it's also that the TGF-beta is going to go on the epithelial cells and say, okay, now make a, I'm sorry if you hear snoring, that's my dog. So the TGF-beta is going to talk to the epithelial cells. At the end, talk to SMAD4, telling produce, become a myofibroblast. But then the SMAD4 again is going to say, become a myofibroblast, become a myofibroblast, become a myofibroblast, and you will have more and more and more and more again. So for all those where you see the TGF-beta, you will have too much of that. So what we want to do, in fact, is to answer to those questions, but we cannot look at all of them, so we chose 3 of them. This one, the epithelial, the endothelial, and the fibroblast. And how are we going to do that? We have the iPSCs, you remember, like a month ago, or no, 3 months ago, I told you that we had patients that gave their blood cells, and from their blood cells, we created iPSCs. So does everybody know what iPSCs stand for? So that's induced pluripotent stem cells. So in fact, we take the blood, we take the cells from the blood, and we modify them so that they become again like the cells that were at the stage of an embryo. So you can take my blood, take my cells from the blood, and transform those cells in the cells when I was just a blastocyte, so a kind of 100 cells that are all the same. So those cells that are like at the very beginning, just after the fecundation, just after the beginning when you start from 2 cells to 4 to 8, 4 to, yeah, every time you multiply by 2. And those cells that are all equal have the ability to become an arm, a brain, a muscle. So that's what we are going to do. So we are going to take those iPSCs, so those are stem cells coming from the blood of the patient, and we are going to transform into cell type that we want. So we want to have them, to transform them into endothelial cells, into fibroblasts, into epithelial cells, in all the cells that we need to perform the experiment of the transformation to myofibroblast. So we are going to start from epithelial cells, so from iPSCs, epithelial, and then we are going to look at the transformation to myofibroblast with the patient cells compared to the siblings, non-affected siblings. We are going to do the same with endothelial cells. We are going to start from the endothelial cells from the patients and then look at the process to go from endothelial cells to myofibroblasts, and that's called EMT, to make the difference between EMT, so epithelial to myofibroblast or endothelial to myofibroblast. And then we are going to take the fibroblast and do the same, look at the transformation into myofibroblast in the patient cells compared to the siblings.
Amel, Anna's got her hand up.
Oh, sorry, I didn't see you.
Okay.
You have to scream because otherwise I just
No,
don't.
it's very interesting and I'm paying attention. And doctor, it has some impact in neurological issues or not?
Sorry, is that I couldn't hear you.
Do you think it has some impact, or you have in your mind some impact for neurological issues for my patients? Because as I told you before, I think the biggest for Paul nowadays is her autism, her intellectual disability, cognition, and everything.
Yeah.
So,
Yeah. So totally. So what we are going, in fact, now today I'm talking about wound healing and fibrosis. But what I like to do is make the parallel between fibrosis in your whole body and something in the central nervous system that is called astrogliosis, which in fact has some parallel things. For example, if you break your spinal cord or you do an injury in your brain, you will have a scar formation, but the scar formation is going to be basically not only, but basically a proliferation and making a kind of glue with astrocytes. And this phenomenon is not called fibrosis, but astrogliosis. So what we want to do is to have this platform on, I'm going to go to the one after. So we want to have a fibrosis platform, but we will also have a CNS platform, so central nervous system. And in this central nervous system, we will have this iPSC, so the stem cells from the patients. We are going to transform them in astrocytes and study the astrogliosis. So that will be the parallel with the fibrosis platform. But those are two different platforms, because you need different cellular models, different assays from one platform to another, because you don't have the same cells in your brain than in the rest of your body. So that's.
Sorry, Killian here. Apologies. I'm still learning the Zoom function of putting my hand up. Apologies for cutting across you. Just one query. My daughter has suffered just recently, just last year. I was away on work, and she suffered hemorrhaging in regards to her period, and it was heavy bleed. And I know I'm trying to understand, I suppose, the different systems. You know, when we talk about fibrosis within the system and its effect on the body, but on the opposite side of it, then we had this bleed and hemorrhaging that occurred, which we had to try and manage with the hospital and try and understand why it was happening, etc. I know they're not. I'm not sure, are they related or not? I know you're talking about two different systems here, but yeah, it was just something in my head in regards to, was there any relationship between fibrosis and the fact that she was suffering heavy hemorrhaging?
Yeah, the issue is in fact linked to the vessels and to when you have an hemorrhage, it comes from a break of the vessels. So the break of the vessels can come, so it's a rupture. So you can have you have different origin of the rupture. You can have the opposite of Myhre, where you don't have enough of this glue, and you don't have enough of the glue in between the cells, and the vessels are going to become bigger and bigger until they break. But that's not in Myhre. Myhre, we have the opposite, that the vessels can become smaller and smaller where you have a stenosis. And when you have a stenosis, if you really close something, then if you take a hose, a tube, and you close it, you might have, I don't say that it's what happened with your daughter, but you might have a rupture in another place. So I cannot tell you just like that's where the came from.
It was just it was unusual in the sense that it's not just once off. It's happened a number of times in regards to heavy bleeds with our period, and I suppose the early onset of puberty as well being a part of that. But it was something that we never really talked about more.
The bleeding might be a problem with the platelets, which are the cells that's in your blood that's allowed to have the coagulation.
Yeah.
And so the platelets are also reactive to TGF-beta, to thrombin, thrombomodulin, and all these kind of molecules that are usually linked to the platelet are also linked to astrogliosis and injury and wound healing. So there is a whole interaction between those cells and interaction between all the different pathways. So the way it acts in the cells. So I cannot answer like that. I mean, we would need to take the cells and really understand if she has a coagulation problem or where it comes from.
Yeah, and it's Killian, it's very common to hear that experience in the community. It's a topic that's come up at our conferences before. I think there's still some investigation as to why that is happening. I think not speaking about Myhre, but in the general population of people who have heavy periods can be associated sometimes with things like endometriosis and all that kind of thing, where you have that the extra bleeding is coming from the extra material and the length of time. I'm not suggesting that's anything to do with Myhre, but it's for sure something that is talked about in the community. She's not alone, and it's something we would love to know more about for sure.
I'm sorry for asking, because I've just have on one side getting my crash course in biology today. Excellent. I never thought I'd do that on a Saturday, but on the other side of it, then you're talking about fibrosis and the way the cells are actually performing, and what is trying to understand. But on the other side, then you have an overperforming system happening as well. I know it's ancillary, it's separate to the two systems and how the cells are performing, but it's trying to get a full appreciation, understanding of what's happening here. The only other question I have is just, I suppose I'm just conscious of everybody's time as well, and trying to get through the presentation material. But tomorrow, for example, if I have to go to the hospital with Holly and she suffers an injury in the course of whatever she's doing today, and it results in a cut or whatever, what sort of advice would I need to have, or what would you advise in regards to what information should I have to hand in when I'm talking to the physician in the hospital?
So that's extremely important. That if that happens, that you go to the clinician and tell them that the Myhre syndrome patient have fibrosis and over hypertrophic scarring that triggers stenosis. So I think what we could do is prepare a kind of card or something like that, or with the reference that you can show at the ER when you are coming to emergency, or that you can show to a surgeon saying, my daughter has Myhre syndrome, the risk are that and that and that and that. So I think we should really work with the medical advisory board on having a kind of really short, not 15 pages of description, but just a short instruction of be attentive to that risk, and that risk. I think
because I think it'd be quite valuable, especially for anybody that has a child that would have a syndrome of any description, that they have that information and be able to present it to the physicians, because the physicians are covering so many different things, and when a patient presents, at least if they have some information and some advice, that they're in a position to make a more informed decision in regards to how to treat the patient as well, like any syndrome.
Exactly. And we've got an emergency card, like a phase 1, that we're just doing some website updates at the moment. So shortly that will be available online, so that you can download that, print it out, and put it in your wallets. But I'm going to work with Armel and the medical advisory board, and just include some extra information to that. And I think what we're going to do is have a QR code on it as well, so that they can then find more, because obviously you can only fit so much on. They can find more information. So we're just working on that at the moment. So hopefully that will be done in the next week to 10 days.
Brilliant. Thank you.
Okay, so does anyone has any question before I talk about the way we would address the preclinical platform, how we are going to why we create that? And I think there are people in the chat. Can you read the chat? Is there anything in the chat? Any questions, Kate? No. Okay. So I have explained more or less. I hope you understood more or less how wound healing is triggered and what's the issue with Myhre. There are not enough studies on really Myhre patients and fibrosis, really characterization, taking the tissue and cutting people and looking at the under the microscope at the type of cells. There are not enough, so we don't really understand what's the mechanisms of those. But what we want to do is avoid to cut the patients And that's the reason why we created these iPSCs at the organization. But we want to use those iPSCs to really create a way to understand and a way to measure potential drugs to act on those issues. So for that, we are creating what we call a preclinical platform, where you will have the cellular models from the patients, and you will have what we call assays. So in vitro means that it's not in animal, it's in cells, so in Petri dish. And we will have the models, and we will have the assays. So the way to measure how things are evolving. Are we going to evolve from epithelial to myofibroblast? And are we going to have astrocytes that become astrogliosis? So this fibrosis of the brain, if you want. So that's the first platform. And we want to create that not only to understand, but if there is anyone in the world who has a molecule, a treatment that says, I think it will work for Myhre, they will have the opportunity to come to us, put the molecule in our platform and test it from the cells, then to the animals. So the in vivo models, that's when you test it directly in the animals, so in the mouse model. So what we are doing now is that we are working with Mark Lindsay from, he's at Harvard, and we are putting his mouse model of Myhre syndrome into an organization that is going to have the mouse distributed to whoever wants the mice. That's Jackson Lab. And so we have also some mouse in Europe so that we don't have to ship the mice everywhere. So those are the two mouse that have the mutation for Myhre syndrome that we can use. And we are going to develop fibrosis and stenosis assays. So that will be mainly in Paris. And we want to do behavioral deep phenotyping. So that will include all the behavior in autism spectrum disorder, cognitive, so intellectual disability, cognitive, ADHD, and any type of psychiatric phenotype. So that doesn't mean that it's for all the different psychiatric disease that we are going to test, but anything that can describe the mouse model on their behavior. So even speech can be tested in mice, and speech delay, hearing, of course, can be tested, and all the behavioral of repetitive behavior, social interaction, obsessive compulsive behavior. So all those are going to be tested with the mouse. So that's the platform. So people coming with solution, they think when they have a solution for Myhre syndrome, they come to us and they put their molecules in that, and we can do all the tests in fibrosis and in CNS, not in everything. I mean, we don't have $10 million per year, so we cannot do everything, but we chose to focus on fibrosis on one hand and autism spectrum disorder, intellectual disability on the other hand. So that's the two focus we have. So to do that, we interact with CROs. So CROs that contract research organizations. So they are biotechs, in fact, companies. We tell them, do that for us, and they do it. We just have to pay them. Like the iPSCs, for example, so the stem cells from our patients, we went to a CRO and we said, okay, we send you the blood, please do that and that. And they did it, and we own the iPSCs, which means that we can use them however we want, and we can send them to whoever we want. So we want to collaborate with academic labs. So that's universities. So we collaborate with CROs and with industry. So we are not going to have a what we call a wet lab, so a lab that is located in a building, but we are working with all these different people to participate in the platform. So there will be the iPSCs, for example, were created in San Diego. They might be differentiated into endothelial cells or astrocytes somewhere in San Francisco or I don't know, Philadelphia. And then those can be tested for example, the primary binding assays. There is one in Barcelona in Europe, and there is another one that is in Emory University in Georgia. Not Georgia, USA. So those are, the platform is, we control everything and we have everything in our hands to be efficient and very fast, but all those experts are in some different places. And what we will have is the way to measure, so what we call in vivo primary and functional assays, and in vivo to validate what we find in the cells. Do you have any questions on that?
Yes or no? I don't know. Doctor, do you guys already have some answer? Because, for example, I did the pharmacogenoma on Nicole, because she usually doesn't answer for medications as should be. So we did the genoma test for pharmaco, and yeah, we saw some alterations, things that explain why. But is it common in Myhre? Because sometimes we test like 20, during her life, 20 medications. And we have success in 2 or 3. Some others are short time. So everything is so hard. And even having the test, the genoma test, the pharmacogenoma test, we don't have all answers for this. So she started medication. For example, now she started atomoxetine. So she was doing great. So now she's very agitated. So we need to stop now for 10 days and see if she has nausea or something like that, and making her more agitated. But she's better for another side. So, but probably I need to stop because she's nonverbal. So she doesn't know, she doesn't explain. And even by AAC is hard. So do you guys have some explanation for this? Because really, it makes me crazy. Sometimes I know it can be horrible listening what I will tell you, but when I see, please understand the best way. When I see some light and the end of the way for fibrosis or another issues in Myhre, and I think, oh my gosh, if I don't have some explanation for neurological part and her behavior, her ADHD, her autism, but the biggest problem I think now is because she's nonverbal and she really tries, but she cannot talk. Even with her highest autism or ADHD, once she doesn't talk, I don't have 100% of my questions answered from her. So when I see a lot of possible answers, and I don't see a lot of things about neurological part, I feel so sad, because I think, oh my gosh, I will have her body good, And I still not have the answer for neurological. So, you know, our life is so hard because of the autism, because of the ADHD. You know what I mean?
Yeah, I think Zach can also, and his wife can also jump on that. So that's the reason why we have chosen to work on fibrosis, because that's health threatening. I mean, that's really important. But the other part where we are actively working on is the central nervous system. So autism, intellectual disability, speech. And this is going to be a big focus for us, because from what I see and what I hear, this is one of the biggest burden on the patient and on the families. So we really want to go in that direction. And the problem with autism spectrum disorders is that it's very specific to some genes. So there are no treatments because the treatments are going to treat something totally different that has no link with MAT4, no link with Myhre, and it's a general treatments that are going to either agitate or decrease the brain activity. It's like if you have someone with headache and you just give ibuprofen, it's not going, okay, you can have a small release, but if it comes from an eye problem, you are not going to solve the eye problem. Or if it comes from a tumor in the brain, it's not with ibuprofen that you are going to solve the problem. So what we want to do is really to find a treatment for Myhre patients in autism and intellectual disability, just for them, because the mechanism that triggers this autism is totally different in Myhre syndrome patients compared to other kind of gene that can be not at all linked, but have at the end the same effect. So that's the reason why we want to have those patient cells from the neurosystem, so the nervous system, the astrocytes, the oligodendrocytes, and all these cells, and test really on the cells. Can we stop this astrogliosis? Can we stop the microglia to behave not properly? And then if we can find molecules that act on the Myhre patient cells, then we can go in the mouse, and then we'll finally go in the patients. But we are really actively working on that. And the other thing that I've been working on almost whole week is to set up a study in behavioral, so for autism spectrum disorder and intellectual disability, starting a study. It's observational, help Kate,
Observational.
Thank you. Study on the patient. Sorry, sometimes I really hit a word that I cannot say.
Yeah, normal.
So we want to select the right survey. So those are questionnaires that are going to help us understand which type of autism we see in Myhre patients. Where do we have to look at? What are the symptoms that we have to follow when we have a treatment that we want to try on a patient? Which
Nicole has a
autism
second
is so
mutation.
large.
Yeah. Nicole
Autism
has a second mutation. So I think it's makes the Myhre harder too, because this second mutation can cause autism, ADHD, and everything. So I think she has a plus, you know.
So that's also yeah.
We had my other son was diagnosed with Asperger's a number of years ago, and very similar, non-verbal, etc. And we explored another technique, or that's what you call it, treatment or whatever. And it was a comatose, if I can remember rightly, comatose intervention, and basically it was to do with wearing certain to explain it, wearing headphones to exercise. The headphones actually were pressure type headphones, which actually stimulated and exercised the inner ear to help him hearing, as well as other methods in regards to touching and feeling. But we've seen significant value in that particular approach. It was done in Ireland by a company called Cluis, which is the Irish word for hearing, and it meant he was able to hear himself speak and helped him with regards to his own speech and his own interaction. But I suppose it was basically taking a non-pharmacological approach, you know, in regards to using a different technique to assist him with that, and he's benefited ever since. But yeah, it was just I think sometimes when we're looking at solutions out there, we kind of look probably pharmacological or side of it. We're probably, you know, I'd be curious as regards diet as well, in regards to what can we do in regards to, you know, improving the diet, and what, you know, things can we bring into that from a natural perspective as well in regards to helping them, whether it be fish oils or whatever in the diet.
We always did everything with Nicole about these things.
Yeah.
But a lot of things she needs to cooperate, and she doesn't.
Oh yeah.
She even can say, stop it, you know? So this is harder because I have a lot of things like in this way to help her, but she doesn't cooperate. She doesn't stop. She, you know, she cannot pay attention because the ADHD. So
yeah,
we tried integrative medicine, supplements, this way, diet, good diet, and everything you can imagine. But really, she cannot.
I think I'm learning as well. So I think I'm learning as well myself that Myhre is also stubborn. They're very stubborn children, very thick. It's just very focused.
It's hard.
My daughter's the same. My daughter's the same.
The issue is that you have so many different type of autism, and everybody is developing one technique there and one technique there. And I think the most important is to start to first understand for Myhre patients, what type of autism are we talking about? Is it sensory autism? We have speech delay. So really, if we start by really characterizing, then we can have a better idea of how to trigger the treatment and where to act. Because in the brain, I mean, speech development is a particular pathway in the brain. Sensory is also a particular area in the brain. And if you have already those deep understanding of the type of autism that you have, then you can, it's a step further, not only because we will have the tools to measure, we know what to look to measure if a treatment is efficient, which is fundamental, because if you can have, I've seen in other diseases, they had a great molecule, great treatments, and they look at the wrong thing. So the patient were saying, okay, I take this medication, I feel way better. Yeah, but the clinician, they look at that and they don't see any improvement. And the molecule was not accepted by the FDA because they didn't see any reasons in what the clinician was looking at. Although the patients were saying, we want that medicine, we want that drug, we want that molecule because it's beneficial. And then the FDA said, yeah, but the clinician didn't show that it's efficient, so we cannot accept it. So really for us, first defining really well what type of intellectual disability, ASD and ADHD we have with Myhre patient, that's fundamental, because that's where we want the clinicians to put their endpoint. So what they are going to measure to see if a molecule is working or not. So we can, in addition to that, we can have all the, I'm sure all of you use them, the stimulation therapy, the diets, everything. But I have seen with my own son who has also autism, it's not, you can improve, you can stimulate, you can have some improvements, but there are no treatments. There are no, there are nothing to really make a difference. So
What I
that's,
can see, it's the speech for Nicole, because she doesn't speak, it's the worst for us.
Mm.
Because she wants, she does blah, 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 blah. She's always trying, but she doesn't connect. So if she talks, but really, I think 80% of our life would be much, much better. And we don't have how to help her a lot, Her brain was different when she was born, and we did an MRI, and I did an MRI short time ago. I can send by whatever for you. And she has difference. But yeah.
Yeah, but we really want to work on that. So that we were yesterday talking with Kate that we need to gather some highly motivated patients just to understand a little bit which kind of survey and questionnaire and study we need to launch, because we can go to the study of general autism. We can include that. Okay, we know that Myhre kids have autism. We don't need this kind of surveys. We don't need this kind of studies. We know they have that. But we need really to study very particular aspects of the disability, so that we can focus on those aspects. And so to choose what kind of study we are going to do, we need to have a few people and that willingly would like to help and tell us, in fact, what's the issue. Is it sensory? Is it repetitive? Is it anxiety? Is it anger issues? Is it frustration issues because you don't have the language to express yourself? So we need, and all those are different studies. So we cannot study everything. That's not possible. It will take 20 years. So we need to start with maybe 3-4 max aspects. And for that, we need people to come to us and tell us in what aspect we should focus.
And Armel, are they telling you the things that are the most troublesome or burdensome for their family? Should they be the things that are the most, because if you're studying them, that's the thing you want to see the improvement in? Or so what are they telling you? What would you like to know about what are those top priorities? Is it because they're struggling the most with them, or what's the...
No, it's not what bothers you. It's really the characteristic, the behavior of your child. What triggers the crisis? In which senses is the most affected? Is it touch? Is it hearing? Is it sounds? Is it taste? So that can be different things, and that's what we need to know. We know there is a speech delay, but speech delay can be can be in different ways. It can be that you cannot pronounce you have difficulty to say the words, or you can have difficulty to associate the words with the idea. You can have everything clear in your head, but the incapacity to make the link to process, in fact, that's what you want to say into real words. Sorry. So can your kids express itself by showing pictures, for example? Is it better in that case? Or is it that he cannot or she cannot process an idea at all? So even if he wants to drink, can he take the image of drink and show you drink? Or can it not say, so even process the idea, I'm thirsty?
Mhm.
So that's all things that we should have a whole conversation with people who would like to participate. I don't want to force anyone, but if there are some people that are interested and would like to have this kind of conversation with us, that would help.
Great.
Yeah, we use it a lot of this that you are talking about, like iPad, pictures, pictograms, and blah, blah, everything. But she really doesn't pay attention. She cannot, the focus, and I think she doesn't copy and paste, like to really can pronunciate or some apraxis maybe.
Mhm.
But,
So
yeah,
if
Zach,
people,
you want to say something?
I think Catherine was agreeing and going,
Okay.
so if people want to drop me an email, I'll put my email in the chat. If you wanted to be in that kind of conversation, and let's just frame that in the sense of it being a discussion, like more of a focus group, discussion point, listening session, from that aspect, then please drop me a line and we can arrange that. That would be really helpful. Just on the point that Anna made about sending us information from your medical records and things like that. If you have information like MRIs or genetic reports and things, the best way to get them to us so that everything is as it should be is to register on our patient registry via CORDS, which you can do on the website. Once you're registered and you've ticked the box that says you're happy to share de-identified information with us, you can then upload reports to your profile. And if you've given us permission to access that, we can then pull that from the system. Now, the one thing just to add on that is when you're uploading any documentation, if it contains any personal information that you do not want shared, please redact it, color it in, cross it out, and then upload your document. That's the best way and the best official way for us to receive any information that's medically related. So please, everybody, if you're not on the registry, please get on the registry because it's so important for all of the work that Armelle has been talking about across every area. I
started. I have to finish. I do,
No, it can you can come and go. That's a good point. You can do a little bit, come back, because obviously the questions we're asking, some of them, it's like, have you had this? And you need to go into a little bit of detail. And as we know, Myhre is multi-system.
Yeah. Is there some problem? It's in Portuguese,
No, you can, if you want to type your information, we can translate it our end.
Okay.
Yeah, no problem. And they are trying to work on having the whole thing in different languages. It's just slow progress.
Yeah, the registry is really fundamental because it's totally legal and de-identified. So we cannot know who said what, but we can study the answers and the patient, really, the phenotype of the patient.
Yeah, exactly. We don't see who has entered any specific information at all. So yeah, lovely. I'm just looking through. Does anybody have some other questions? Armelle, did you cover everything?
Oh, we are over time. I didn't know.
We're about right. I think I put them in for an hour and a half.
Okay.
Yeah. So shout now if anybody has some questions. Please let us know. Oh, Zach.
Just for next time. Although today was supposed to be fibrosis, there seems to be a pretty significant demand for talking about the mechanisms in the central nervous system that might be affected by Myhre. Do you think that we could have that as like a topic next time?
Yeah, I can. I'm a neuroscientist, so of course, talk about that. I would be really happy. It's going to be a bit of a challenge to make a link with the Myhre patients because there's nothing studied on Myhre patients in CNS. We have a few MRI showing that there are some hypersensitivity white matter which indicates demyelination or non-myelination. So I can talk about that, and I can talk about the really basic science in neuroscience and SMAD4, but we know about the wild type, so the non-pathological SMAD4 in CNS. We don't know about the Myhre SMAD4 in CNS. But I can definitely talk about that, yeah.
Great. Any? Yep.
No, just a question again, just back to injury, I suppose, and always conscious of, maybe it's my job, I just think of harm and things like that after. Is there any, when we talk about back to fibrosis, is there any injury that we need to be really aware of or be conscious of, that should the injury occur, that with the knowledge that we have in regards to fibrosis, that would represent a higher risk than normal? Is that am I phrasing that question correctly? So whether it be a cut in the hand that deemed as a low risk versus a cut to another part of the body, or a head injury, for example, should Holly suffer a head injury in the course of sport or in the course of her day, which would be more of a higher risk type injury, you know, if she was to present in the hospital when we now have this knowledge about fibrosis?
Well, the tracheal is really an injury where you can have issue. So everything from the, not really the deep lungs, but everything that is before that is very sensitive with Myhre patients. I would say the ear injury can be also not really good. And for the rest, it's not injury that you can trigger like on your heart, on your aorta. If you have an injury on the aorta, that's well, that's already really extreme case. So in terms of injury, I would, for example, tell her never smoke, or but no, for the aorta you cannot precise that.
Zach's just jumped in with a great point. Zach's saying not related to fibrosis, but we be aware of pericarditis. Killian, I don't know if you've had a chance to have a look at the handbook yet, and Mark Lindsay has done some talks on this on our YouTube page. I can send you afterwards and direct you to those. But we've seen in some cases an acute onset of pericarditis. So if your heart, if there's a balloon in a water bottle, and you fill up the water outside of the balloon with too much water, the balloon cannot blow up, inflate, and that's what acute pericarditis can do. There can be too much, all of a sudden, too much fluid around the heart muscle within the chamber, and it's restricted in its ability to move. We have seen a couple of cases of acute pericarditis happen in the community. I'm not giving medical advice right here. I pretend I've now got my mother hat on. Mark Lindsay said to me, if, for example, your child, it can happen, the onset can be for something unrelated, so like flu or an infection and something like this. I don't exactly know why it happens. So just that awareness of, if they're not responding or not getting better after a few days, if you are not comfortable that things are heading in the right direction, get to the ER and say to them, there's a risk of pericarditis, please scan immediately. So again, we will make sure that information is on the card, but that's just, there's a low margin for ensuring that that is checked, because we've seen that with a few cases. So yeah, pericarditis, I can send you some more information on it.
Especially with the onset of COVID over the last number of years as well. In another complication on that, you know, just the relationship with COVID and
Inez has also asked about PVL, periventricular, I can't say it.
Leukomalacia, periventricular leukomalacia. Katie has it.
Well, it's always the same. If you have a kind of aggression of the cells around the aorta, around the vessels, around the heart, and or around the trachea. If you have a kind of stress or aggression, then you are going to trigger all the process that I talked about. So that's any kind of virus infection, bacteria, as I said at the beginning, is considered an aggression and can trigger the overreaction of this wound healing process. So that's but we don't know exactly what triggers that, besides virus that we can imagine, or bacteria, or for the skin, it's really when you have a scar. For the intubation, that's an aggression, of course, and triggers really wounds. But for all the rest, that's it's limited to a restricted number of tissues. That's great. We don't have fibrosis in every type of tissue in Myhre, but in those tissue, any type of aggression is going to trigger the wrong answer.
Dr. Nicole has a lot of constipation. Her
Yeah.
motility is very, very slow. I always have to help her. For example, if she eats a pizza and on weekend, I have to give some Miralax, for example, and prevent to help her so she goes to the potty and will not be constipated right after, because she was hospitalized 2 or 3 times because of this before I know exactly how to do. Why are they so with the motility so slow?
Yeah. So I was talking about that just a few days ago with Angela Lin, who's the Myhre specialist, and I was asking, do you see any kind of fibrosis in the gastrointestinal tract, and do you see specific stenosis? Do you have any biopsies that we can really go and look at the cells? And she said, no, we know that there is constipation and we have no idea what's happening. So again, we need to start investigating on the mechanism.
Nicole did the endo and the colonoscopy,
Yeah.
and she doesn't have anything. She has reflux, so she has some I forgot the name. Reflux because of the
Reflux.
I
Yeah.
forgot.
Yeah. From the
Yeah,
stomach.
yeah, but
Also an issue with the that can triggers also.
yeah, I know, but she has some scar like inside. She's a little bit inflamed here because of the reflux. So she takes like domperidone. It's not allowed in the US, but here it is. So she takes a little bit in the morning to help her. And, I have to control a lot her diet, but she doesn't have anything in her intestine and everything is normal, but she's slow. I don't know why.
Yeah, and they don't know why, but to understand why, we need to have at the cells and see if it's a problem of electrolyte, if it's a problem of the smooth muscle cells that should in fact work and contract and do not contract. So we cannot know just out of the blue like that. So we need to study it, and nothing has been studied yet. But yeah, we are going to look at that. It's not the priority. The priority is really the fibrosis and the behavioral, the autism and intellectual disability. But that's definitely gastrointestinal is definitely an issue that we need to address one day. Yeah.
Okay. I know we're slightly over. I mean, and I know we could always stay longer and talk all day. There's so much to cover. But do shout now if you have any final questions. The next one is in a month. I will send out details for the Zoom for that. And as ever, thank you so much for your interaction. Thank you, Armel. These are just amazing. I know the community is loving them. Please send these on YouTube once they're there. Please send them to friends and family who want to know more. I know my family have appreciated understanding the factory manager thing.
Thank
So
you
yeah.
guys for always staying in us and all team. Thank you.
Oh, pleasure. And if anyone's around and want to talk later, it's coffee hour weekend. So we're here to chat less formally. Don't expect the same level of knowledge from me that Armel brings you, that's for sure. But we're here to chat about community stuff, what's on your mind, just get to know each other better. So there's one tonight and one in the morning. Again, details on our website under the events page. Other than that, have a lovely rest of your weekend.
I will try.
Thank you,
Thank
guys.
you so much.
Thank you.
Thanks.
Bye
Bye-bye.
bye.
Bye.
Thank you,
Thanks,
doctor.
Kev. Thank you.